Well, good afternoon. We're live. Thank you for joining us. RE Journals, Minnesota Real Estate Journal, Illinois Real Estate Journal, Red News in Texas. This is a Minnesota CE event, so I expect a lot of people on here from Minnesota. There we go. There they are. They're starting to come on. Thank you all for joining us. I got to go over some housekeeping items first before we turn it over to our panel. First of all, thanks to SIOR. They've been a marketing partner of ours on all these webinars. Without sponsors, we wouldn't be able to pivot into these webinars, and frankly, we might not know what day of the week it was if we didn't have them to go by. This is us now. In case people didn't know, we joined a larger group. We now produce 6 publications in 17 states. We're on track, still on track to do 104 live events this year. Add to that, we're getting close to 50 webinars. So this is, let's see, I got to read this. This webinar has been approved by the Minnesota Commissioner of Commerce for 1 hour of real estate continuing education. This first bullet point here is the important one. How do we track attendance? So when you come in, your name and that you've logged in is time-stamped. But just in case, belt and suspenders approach. I see a lot of people are already doing it. Go in the chat room and pop in your name one more time. Then it makes sure that when we go back and look and have to check your name off, that we for sure see it on there. Especially if you ended up logging in on our generic login, we may not get that. So thanks for that. During this event, I'll pop in and ask 2 questions randomly at random times. All you have to do is go into the chat room again and answer those questions. That's how we track your attendance. We don't have software that can watch your computer and make sure you don't go to another screen like others do. We just go by this chat room. So that's our thing there. If you have connection issues, I'm looking at our server says 5 bars. So if you have a connection issue, most likely it's you and not me. At the top of the screen, you see a reconnect button. It's red. Hit that button. So somebody freezes up or you hear their voice doesn't quite sound right, reconnect, and that solves 99% of your problems. If you're continuing to do that over and over again, it's not working real well, check that you're using Google Chrome if you're on a computer. That's the best software. If you're on your phone, if you're on an iPhone, use Safari. If you're on an Android phone, use Chrome. You can also switch to an iPad or anything like that, or a different device if you want to, if you're having connection issues. That chat room I already talked about, that's to your right if you're on a computer, below you on your phone. Polls. If I throw up a poll, you know what, I'm going to skip polls today because that messes up the CE. We do have a YouTube channel, so you'll be able to view this as well as all of our other webinars on lots of different topics on our website, rejournals.com/videos. Yes, Minnesota Real Estate Journal website now points to RE Journals, where you can get news on all 17 states. If you want to just see Minnesota, we have a really cool drop-down menu. Just pick Minnesota, and you can see it just like the old Minnesota Real Estate Journal. Okay, here we are, COVID-19 and the effect on healthcare and medical properties. Whoops, wrong button there. We've got a wonderful moderator here, Chris Jacobson. He's going to take it away. I'm going to disappear, but if you all need me, I'll still be here in the background. I'll monitor that chat room and pop back in for our questions. Thanks. Take it away, Chris.
Thanks, Todd. Appreciate it very much. Hello, all. My name is Chris Jacobson. I'm a CCIM and a real estate advisor, healthcare advisor at Lee & Associates with my real estate partner, Susan Wilson. I'm honored to moderate today's panel of distinguished colleagues and, frankly, friends at the Minnesota Real Estate Journal's webinar, COVID-19 and the Effect on Healthcare and Medical Properties. Today's panelist, Chantilly Milibago. She's Director of Real Estate and leads Mortenson's National Healthcare Vertical. She's responsible for driving strategy and long-term growth. We used to work together. And her name has 27 syllables. Brian Bruggeman is CCIM and SIOR. He's a Vice President at Colliers International in the Healthcare Services Group. Brian focuses on healthcare providers with their real estate needs around the Twin Cities and surrounding area. Brian is also the Director of Real Estate for Alina. Erwin Effler III, he's a MHA MRED and Vice President of Real Estate Development for Ryan. Erwin works closely with customers across the nation, facilitating their growth strategies through end-to-end strategic real estate and facility solutions. He's an awesome resource. I call him often. And Mark Davis, principal at the Davis Group, is considered one of the foremost experts in healthcare real estate in the upper Midwest. Mark leads his development teams, including design, leasing, investment sales, and a wide variety of advisory. We're looking forward to hearing insights from our panel of clearly experts today. And with that, I'll start with a conversation with a question for Chantilly. Chantilly, what is the impact COVID is having on healthcare systems locally and nationally, and what impact might it have on their portfolio and asset mix? And then others can chime in once she's gone through that.
Sure, Chris. Thank you for the question. I'd like to address the question maybe in a couple of ways. First, COVID is impacting our healthcare markets, the healthcare sector, from a financial standpoint. We all saw the headlines locally and nationally. Elective surgeries and procedures were canceled early on to make room for COVID patients. So this, along with deferred visits, reduced patient volumes, resulted in reduced workloads for providers and subsequently reduced revenues. And so systems across markets are experiencing anywhere between a 40 to 60% drop in revenue. Now, couple this with the increase in expenses to manage the COVID response, and the financial pressures are tremendous. Similarly, the impact COVID has had on our local economies also affects the healthcare industry. And so what you'll see is, many previously commercially insureds may, as a result of job losses, become uninsured. And so the trajectory of the local economy impact is truly dependent on how our economies recover. The second way that COVID is having an impact on our systems and on the healthcare market sector is an acceleration in changes of care delivery. And so to address COVID, we saw the quick reorganization of critical care on campus, right, to isolate COVID cases. And investments were made on campus to enhance infrastructure and also to convert patient rooms into ICUs. CMS, the Centers for Medicare and Medicaid, also reorganized quickly and expanded reimbursements for previous inpatient services to outpatient settings, as well as expanding reimbursements for telemedicine to include care across state lines. And so now some are questioning whether CMS changes will continue beyond the pandemic, particularly for telemedicine. But for the customers that we're working with, telemedicine is here to stay. And so in terms of what the portfolio asset mix will look like moving forward, really it's a function of strategy. And it's a future where critical care will continue to take place on campus, in hospital, with more and more services being driven off campuses to lower sites of care, whether taking place in an ambulatory facility, leveraging telemedicine as part of that care delivery strategy or other. And just a quick comment, asset mix is always an output of a healthcare organization's mission objective and market strategy. And so factors that'll drive asset mix are optimization, meaning optimization of operations and subsequently its real estate. And that optimization of operations could include examining areas of the system's organization for redundancy, for gaps in services, for market share. As an example, are there any underperforming service lines? Are there opportunities to double down on higher margin service lines like ortho or cardiology as systems look to recapture revenue moving out of COVID? Flexibility is also important in terms of what a real estate and facility strategy will look like. How can assets be positioned to quickly accommodate for changing care needs? As an example, should another pandemic occur, how can we quickly, again, have rooms available to convert to ICUs without the heavy lift that our systems went through earlier? What kind of centralized services are needed to better serve a community, such as centralized lab? And then lastly, in terms of real estate and portfolio outlook, or what an asset portfolio mix could look like, is community health needs. Healthcare serves local communities, and the priority of health needs will differ across markets. COVID highlighted that for us. And it's also highlighting the disproportionate share of communities that are being impacted by this virus. So for some urban markets, as an example, along the West Coast and East Coast, pre-COVID, many were expanding their care services to address social determinants of health. Ways to address health disparities that might be caused by socioeconomic status, lack of housing, education, access to care. And so what we'll see, in addition to on and off campus strategies for some markets, are real estate and facility outputs that'll help the healthcare organization address health disparities in order to keep their patient populations healthy and to prevent costly or chronic conditions such as hypertension, diabetes, etc. So at the end of the day, when it comes to the healthcare portfolio, the portfolio coming out of COVID will be optimized, it'll be flexible, and he'll be strategically positioned to address the community health needs and priorities.
You may want to pony in on that. That's a lot of really great points.
Yeah, I would say very well said, Chantilly. I think and three things that we're kind of seeing with healthcare providers now are could probably be summarized in thirds. You know, about a third of the people are really struggling with this and trying to figure out what's next and how they're going to survive. A third are kind of probably sitting there saying, wait and see how this all shakes out. And then about a third are saying, moving forward with their strategy. They still have cash. They know what they want to accomplish, and they know where they need to be, and they're still moving forward with that strategy when it comes to development or expansions or planning their ambulatory network. So I think hopefully as the stock market comes back and there's more activity out there and the path becomes clearer, hopefully that other middle third will start rejoining the group as well and moving forward.
Hey, in the interest of being random and getting one question out of the way in the chat room, so if you're here for CE, real quick, is a yes or no answer. So listen to me, give you 2 seconds to pay attention. Okay, yes or no answer in the chat room right now. Have you, as you or your company, deferred or canceled any capital investment projects? Currently deferred or canceled any capital investment projects? Yes or no answer is all I need for continuing to add. Thank you. Going away again.
No, from the Davis Group side.
Well, with that, Mark, let's step into the second question.
Perfect.
Mark, are deals still getting done, leases, development, acquisitions? And I would also throw a follow-up onto that I don't think came up before, but what about are landlords looking for more guarantees or more enhancements because of the current situation?
Great, thanks, Chris. Kind of going on what Erwin just said, across all of these areas, we've kind of gone from our tenant and clients going from panic to really having more time to focus on, potential strategic issues. And so we found that most developments that were already started and ongoing have continued to be. Nationally, we're seeing that, most of the mid to high credit systems are continuing along with their development projects, while those that are less than investment grade really have put those on hold. From our local experience, we started a small development project a couple weeks ago in Rosemont. We've got 2 more on the docket that we think will get started by September, October. And the thing that's really helped push those along are the fact that the physicians during this time of not being able to go and see patients as much have really had time to reflect and think about their consolidation strategies and some of those other things. On the acquisition side, we've seen a fairly dramatic slowdown. People really didn't want to get on a plane, go do their due diligence. And so I think the second quarter results nationally for our healthcare investment activity will kind of prove out that we've had a dramatic fall off in those. Cap rates, I think because of the uncertainty, there's been a lot of national lenders that have backed away just because of the risk profile currently in the marketplace. And so they're only starting to come back. One of our counterparts on the East Coast had 2 development deals where the lender actually backed out of the deal, and they had to go source additional financing. Most of your large healthcare REITs, because of the dramatic downturn in the stock market, have really been sitting on the shelf, for the past 60, 75 days, and really haven't been in the acquisition market, which has, of course, provided us opportunity. We actually had 2 buildings under contract, LOI in Connecticut. And one of the things that happened with the dramatic downturn in interest rates, you think it's all good, interest rates, how can they not be bad if they're lower? Well, in this particular case, the seller had defeasance on their swap, on their loan swap. and they were anticipating about a $650,000 hit to pay that off, and it turned out to be 1.3 million to the fees, and really had put that on hold. On the flip side of that, we're in the process of buying 3 buildings in Tennessee right now, and the price we've negotiated downward based on kind of the COVID hit and the concern in the marketplace has slid the price about $2 million on a $40 million deal. So there clearly is some softening of the cap rate marketplace nationally as we look at these. On the leasing side, we've seen a fairly dramatic slowdown. Renewals, of course, are still getting done. I think a lot of systems, and Brian can talk to this, but a lot of systems have put a number of their leasing projects on hold, and we've clearly had some of those where we were at lease or close to at lease, and have had things put it on hold. But generally, we see as COVID is kind of pushed through and our physicians have gotten back to work, we're now seeing a lot more positivity in the marketplace and a lot more activity starting to develop.
Sure, I can piggyback on that a little bit, Mark. We've seen a couple of things happen on our end. From the acquisition side, we've had a couple sellers who have decided to put their properties on hold and not put them on the market until they really evaluate kind of the uncertainty in the market and really have a better understanding of what the capital markets and cap rates on these type of products are going to be like. From the leasing side, a lot of leasing has come to a standstill as either physician groups or systems really try to figure out what sort of capital that they do have still in place. They're going to see a dramatic effect in their cash flow as a result of COVID-19, and I think you'll see almost an echo effect of that as their billables stop coming in for the work that wasn't been able to be completed in the past 3 months. So they're really going to try to reevaluate and assess where they're at from a financial position. Additionally, we've had some deals that are put on hold, not necessarily due to capital constraints, but really as these groups reevaluate how they're going to be approaching their healthcare delivery model and whether or not brick and mortar is necessary, or due to COVID-19 and their sudden having to shift to telehealth, is this going to work for them in a cheaper model than having to have that overhead of having the brick and mortar. So in some ways it forced them to rip the Band-Aid off and really go to a telehealth type model, and they're kind of in the position right now to seeing if that's sustainable or not.
Chris, to your other question about credit and whether or not we're all going to really focus on credit more as we go into the future. You know, some markets nationally, they still have lease guarantees on virtually every lease in their marketplace, or a large portion. The Minnesota market clearly hasn't had, not that there aren't personal guarantees that happened depending on deals, but for all in all, you know, we don't have a big personal guarantee market here. But I think you've seen a lot of national REITs that have really spent more time. They've instituted credit departments within their organization. The investment market is so attuned to, you know, defaults that occur in their portfolios and the impact it has on the concern of the health of their portfolios. One interesting note, so when we started this whole COVID process and started to be concerned about, you know, what would be the impact on rents, are tenants going to pay, when will the financials start to deteriorate? In April, we ended up getting a 98% pay through. We gave assistance to 5 small, really dental tenants that needed help. All our big players paid. And we really think that the revenue is, as Brian just said, revenue was still coming in, you know, from the earlier February and March timeframe. You know, then we got to May, and for many of our smaller to mid tenants, non-big health system, they received their PPP loans, and that really gave them a boost for May. And again, we got into the high 90s portfolio wide. And now June, we've just hit over 90% collection, you know, in the first 9 days of June on our portfolio. when we look at our combined 60 building managed portfolio, we're up in the 96, 97% pay rate. What will be interesting though is Brian just commented on what's going to happen now as we go forward. Are people going to come back? Are the surgeries going to get to the level and the patient visits get to the level to drive revenue? What will June, July, August turn out to be, and how long is the recovery going to take? And will we actually experience some delayed pressure, based on that lack of recovery or not? So we monitor that closely, and so far we've been pleasantly surprised by the vibrancy and the health of our tenant base.
Yeah, go ahead.
I'm done.
Oh, okay. I think this is a really good segue. Mark, to your point, when Sue and I have done work nationally, Seattle especially, DC, New York City, we've had guarantees every single place we've gone there. Locally here, we rarely do, and I think it's under certain circumstances. But we've been very busy since COVID started, and an awful lot more lately. We've been bumping into at least the question, if not the requirement of it. But I think that brings into the next kind of 2 points, which is, and you touched on both of them, Mark, but I think it would be good to get feedback from both Erwin and Chantilly, and for sure Brian. Did people see a lot of tenant assistance coming into play during this initial stages on it? And now that that's starting to kind of elective procedures are coming back on, what does reopening look like? And I think those two questions are kind of sewn together, because one is, what happened as a knee-jerk reaction to kind of save the day, and then second thing is, how do we come back from there?
Yeah, I would say, continuing on that theme and that question, for us at Ryan, we play in all the major food groups, and healthcare was definitely hit the hardest. Part of retail as well, although we're not in the retail segment that got hit particularly hard, as we tend to work more with grocers and stronger retailers. But we think that healthcare will come back the strongest too. And it's been interesting to see that, there's been an insatiable amount of demand for healthcare investment over the past 5-10 plus years. And especially really in these times. So it was kind of counter to for the reasons that a lot of people are investing in healthcare. But it's so demand driven. It's need based. It's need based on our aging population, and everybody needs healthcare. So it's very understandable what happened and why healthcare was hit hard here. But there's no doubt in everybody's mind that it's coming back fast. So slightly contrary to what Mark said a little bit, for the best core real estate assets, the pricing is still strong and investor demand is still strong. And as Chantilly said, financials have been hit hard. Credit ratings, might be hit, but investors are still looking at this as a very resilient and strong sector. So I think opening up, we've had this 60, 90 days. There will probably be a period where the future is somewhat uncertain, but healthcare is going to come back strong. And all the different providers I've talked to are definitely talking about more telehealth and potentially reducing their footprints in this as well. But the need for physical space and bricks and mortar will always be there in healthcare, and especially as things recover. Not everybody is comfortable with doing the telehealth, but the younger generations are.
I just want a quick add to that, Erwin, and I agree, healthcare will come back. In terms of what that trajectory looks like, I think it's going to differ across markets, and it is going to differ based on how health systems were impacted, particularly financially by COVID. Also, what will influence the trajectory of how healthcare will come back, and it ties into what my colleagues are talking about in terms of how will healthcare delivery change moving out of COVID. How where and how will telemedicine play a role is really around consumer behavior. When will consumers feel comfortable to come into the healthcare settings? And in part that will be dependent on how our healthcare organizations in a sense, marketing to their community and to their patient base, letting them know that, hey, it's okay to come back. We're here. Healthcare is here. We're here to help serve your needs.
Yeah, and Brian, I'm really curious to hear how you feel about both those, both Chantilly and Irwin's and Mark's statements on this too. I mean, considering unemployment was hit the highest in healthcare for sure across the country, and then frankly, from director of real estate for a provider, in-house provider standpoint, what does reopening look like given that? And frankly, who's struggling?
Sure. Well, there's a couple questions there. I guess who is struggling? I think most healthcare groups are struggling right now, and they just need to figure out how to get their cash flow back in order and their balance sheet corrected. Initially when COVID hit, our clients, we'd have discussions with them and really try to just ease the panic and tell them, let's just step back and really just have a real mindful conversation about this. And a lot of times we just ended up approaching the landlords. Most landlords were agreeable to work out some sort of win-win situation for both the tenant and the landlord. Now coming out of this, as the receivables are going to likely diminish due to the delay in work for a lot of these groups, especially surgery centers and these groups who, through executive orders, were unable to perform a lot of these elective procedures, which are really high revenue sources for these practices. Coming out of that, now they're trying to figure out, okay, was this just deferred demand and are these cases coming back? Most groups are thinking yes, but now they're running into the issue of facing capacity issues at these ambulatory surgery centers, where they're going to be really fighting for space and for time in the OR, and likely having to prioritize procedures. So it's not going to be all this revenues coming back in at once. They're really going to have to figure out how to fit that in, and really adjust to the backlog of procedures, as well as the new cases coming on board. So there's going to be a little bit of a bottleneck, I think, at these surgery centers, which they're going to have to figure out how to address. How things look opening up in the future, from the system perspective, we're doing different things. It's just testing patients and triaging patients in the parking lot. So it's been a lot of work dealing with leases and having to go through those issues, because a lot of lease premises, you're able to operate within the four walls of your lease suite, but the parking lot isn't included in that. So we've had to really run through the exercise of putting in licensing agreements that allow us to get tents up in the parking lot, which is really for safety of the community and safety of the healthcare providers, and just having to work through that. And it's been a great team effort. All the landlords that we've had to deal with here in the Twin Cities have really been on board with finding a solution that works for both the tenants and for the landlord, and they've got to protect their interest and their asset. And certainly the insurance indemnifications are something that comes up in those instances. But I think we will start seeing some sort of normalcy. It's just a matter of what that new norm looks like and how they're going to be able to take on this income of backlogged surgeries and cases.
Yeah, I think income and backlog, I think, are two huge things. I mean, especially when you look at, like, for example, I think two of the most major adjustments systems made, probably Mayo for sure. They went all in on COVID, and then also so did Fairview with converting Bethesda to a COVID facility, and now as much of St. Joe's as they've moved over. That undoing of some of that stuff. Is Alina? Did they make those kind of major adjustments like those other two systems did?
Alina did not have to build any additional brick and mortar structures. They were able to retrofit and basically redesign existing space to meet those capacity demands and adjust for COVID-19.
And then will that take time to undo, do you think, or how will that work out?
My understanding is it's largely modular, so I would think that it's going to be less intrusive than one might think, but we're still going to be dealing with COVID-19 cases for the foreseeable future. So I don't think that that's something that's going to go away in the next 60, 90 days.
And then everybody else with what Brian's been saying here, are you guys bumping into those kinds of things with the people you work with, the systems you're working with in your buildings?
Chris, in terms of infrastructure improvements?
Yeah, like, I mean, if you had have you had people making physical adjustments to their to existing facilities to try and take care of ICU type needs for COVID, and now they might be undoing those as hopefully this gets less. For example, New York City finally had a day without deaths and only 35 new cases. So I mean, when you look at them having, I think their peak was in the 4,000 or 5,000 cases one day type thing. Now that they're undoing, Central Park, it's kind of a big change.
I would say yes. Some of the systems that we work with on the West Coast, certainly, quickly made some infrastructure improvements to accommodate for COVID cases. Everything from HVAC improvements to the conversion of rooms to ICU to temporary testing sites. Temporary testing sites, perhaps over time, yes, will go away, but some of the infrastructure improvements and some of the conversions that were made, they were done in a way to create flexibility for the future, so that as a surge occurs, they can quickly readapt, quickly address COVID cases that come in. So this, and in thinking about what the future facility looks like, will continue to involve flexibility within that existing space.
I would say too, we ran a bunch of different scenarios for different health systems. Our design team was working with various health systems in town to look at how they could repurpose or underutilized space to accommodate patients. We poured pads for temporary morgues behind a facility in town. We also we're building modular clinics that were shipped down to Washington, D.C., I believe, with our construction team. So we did do a lot of those things in the early days, and kind of when the panic was going on and we didn't have all the data. I would say the vast majority of those things were exercises and good to have, good to know, but ultimately were not utilized, thankfully, for a lot of us. But most of the systems wanted to know, what can we do? What if we needed to? And by that time, things were already slowing, thankfully.
One of the other things that we saw is, whether it's from a system or larger independent practices, is them really just designating certain facilities to be, quote unquote, COVID facilities, where that's where you go to get your tests and your treatment done, where the other facilities are the healthy facilities, where if you just need your routine checkups and things that aren't COVID related, you would go to separate facilities. So really trying to delineate and really steer their patients towards facilities depending on what their need is.
Anybody else on that one? Well, maybe we should bring this back a little bit more to the technical financial pieces of this. So Mark already kind of touched on this just briefly back when we were looking at what kind of transactions are still getting done. But let's come back to mergers and acquisitions activity. What do you guys see happening? And do you think it's just on lull, or do you think it picks back up again, or what do you think this impact will have on it? I mean, maybe Brian, because you're in house, maybe you want to lead this off.
I don't know from the in-house perspective. What I will say is, from the independent practices that we deal with, it's already oftentimes a tough business to be an independent physician. So blips in their cash flow like this and financial strains that COVID-19 has caused them might make them reconsider aligning with a healthcare system or private equity group to really just spread out some of that risk and just recapitalize themselves. So I think that's something that you will see, or at least those conversations happening. And with real estate, I think a lot of those strategic plans may be on hold as they evaluate whether they're going to align with a system, private equity, or remain independent.
And I think you've seen that nationally, where there's been a big wave over the last couple of years of private equity groups acquiring multiples. It depends on specialty type, of course, but in our local market, we've had that's been a pretty aggressive group type that has sold out or in some way positioned with private equity. We've seen that nationally a lot. And I don't think that is probably going to slow down. Back to the credit issue, this changes your whole kind of evaluation. You've gone from assessing the local group that's been in the market for 20 years. Now you're relying on a combined group credit. And, are the decisions they're making in other states going to impact ultimately, the credit of the overall organization? And, we've had a number of groups now come to us and want to assign their leases from the individual medical group to the larger PE entity. And that brings a whole new evaluation on credit and risk, that we've started. But I think that trend will continue. I think nationally, some of the large merger combinations will maybe go on pause just because of the financial impact in assessing that. But we have seen no slowdown in the number of groups that are looking to combine with others or sell out into a PE type organization.
And Chris, I believe we're going to see, continued M&A activity, across healthcare systems as well. Pre-COVID, and maybe I'll say this, much of healthcare across various markets are really dominated by the nonprofit healthcare system. There's both for-profit and there's, of course, the not-for-profit healthcare organization. Pre-COVID, we saw the merger and combination of healthcare organizations such as Dignity Health,
Yeah.
Common Health, yeah, exactly, into Common Health Spirit with Catholic Health Initiatives. That's just one example of some pre-COVID activity. As we're coming out of COVID, those healthcare organizations, those health systems that pre-COVID were already constrained financially, that may not have had the operating margin needed to reinvest into its operations, they're going to become a target for some of the larger healthcare organizations. And maybe I shouldn't say target, but really they might, in order to continue serving the community, will need to turn to some of these larger healthcare systems for assistance to be able to continue bringing care into those communities.
I think too, it's interesting. You really have to evaluate more closely how those systems or hospitals that were great acquisition targets once upon a time, and people would have been chasing, fit into the broader network. I think too, we'll see more closures. There was a hospital here in Minnesota that put itself out there for sale, and none of the major systems responded to it. They didn't want to buy it. The financials weren't good. It didn't really fit into the care. I imagine they were sitting there saying, "Oh my gosh, nobody wants us. How are we going to?" That really changes the story for their board. What do you do now with that community and that hospital? So, and I think things have changed since then. But really thinking through, what you're taking on and how that fits into your broader system is really important in today's environment, pre and post COVID.
Yeah, Erwin, I think you nailed it right on the head. I mean, Sue and I working on, I think it's either 2 or 3 hospitals right now, I can't remember. Catholic Health closed 2 in the past 5 years, and they basically, even though they're critical access hospitals, they still one had I believe 24 beds, the other one was a little larger than that, and they just aren't replacing them. And now with the long-standing moratorium on hospital beds in Minnesota, it just doesn't seem like there's an appetite to add more beds, which is interesting. And I think that certainly the outpatient model is taking over, so that some of that goes on that way. But I think you're right. It is weird when you get a hospital that's, even if it's a little dated for sale, and we have one of them that's only 15 years old. So I mean, it's just odd. I think you bring up a really good long-term trend. While we're at this, why don't we grab a couple quick questions from the audience? Stuart Ackerman asked a really good question. I think, Erwin, since you're shipping some around, and we have a little experience with this, Sue and I do as well, but what does a modular clinic look like?
I think there are many different variations out there. The particular ones that we were working on, and I was not close to it, but what I did see is that we were taking containers and very quickly retrofitting containers to have 3 or 4 rooms in there that had an exterior door into each room. So somebody could go in there. These could be quickly moved, shipped around the country, placed. People could walk in, get tested, and walk back out. And not necessarily for COVID, but if you had to use it for some type of primary care. I think it was HGA and McGuff or somebody they worked on something and had a lot of publications out there for a while that kind of looked like the military tents and stuff you saw in Central Park in New York. So I think there are a lot of different varieties out there.
Yeah, and there's some real hard ones too. Sue, myself, and Steve Brown's team went to Michigan to see Steelcase's healthcare delivery lines, and one of their new mechanisms is a modular room that's has a louvered roof, so that it can be it doesn't necessarily have to be sprinkled, because it can open louvers and sprinkles can come in, or if there's someone in the room, it can close itself off and have a sound capability and other deliverable capabilities. So they're actually little modular rooms that can be moved, reused, and repurposed. They're not quite, audio capable yet, but they're high for HEPA and things. There's a lot of solutions out there. Sonia Schneider also had a question that I think we should just grab quick too. All the data shows that HVAC can have a major impact on spread. Our healthcare organizations addressing this with owners and making changes to create better and healthier facilities. And before we touch that, I would just say I read a Harvard study just the other day that says over 92% of the transmission is airborne. Less than 8% of it is through touch. So to that question, it's a good one. Anybody want to touch that at all?
I can jump in. I think that's one of the issues that we're all going to assess here closely as we go forward. Getting more air exchanges in our buildings, using HEPA filters, and will it have a true impact? I mean, we've had HEPA filter and high air exchange in ASC and surgery centers, forever, and which is a required code. Will we actually do that for our entire building, and will that expense be warranted in the prevention, that we experience going forward? So I think that's something that we're assessing. We have our mechanical engineers looking at those particular issues, especially on new developments, to see if we should be making changes or considering changes that will have a long-term meaningful impact.
And I think that's true for not just healthcare facilities, but as we all prepare to go back to the workplace at some point too, the office space, and for all the different people on this call, how about your average office building in the community and especially big open spaces? How are those HVAC systems put together, and will that protect the occupants in there? I think is a question everybody's got to take a look at.
And just real quickly, part of the maybe slow in advancing capital investments across the healthcare organization is in part, trying to evaluate and assess, to Mark's point, what capital priorities does the healthcare organization need to focus on? One of the healthcare systems that we work with out west is prioritizing across their owned assets ways to address and improve the HVAC infrastructure in their ambulatory facilities. And so it is something that healthcare organizations are assessing and are making appropriate capital prioritizations around.
I think the question too also is going to depend on whether it's an owned asset or a leased asset. We spend a lot of time on leases, really getting the nitty-gritty negotiation of what is included in an operating expense versus a capital expense. So at some point, somebody has to bear this cost, and you're going to have to really dig into the leases. And if it's a multi-tenant building, there could be multiple leases to figure out what the landlord can do, if they can do it, and who pays for it.
Great statement. Let's use this as a transition back into the impact of COVID on capital expenditures, cost of capital, and valuations. Mark, you touched on it a little bit earlier, and I thought it was a good segue to it then too, but let's go right back to it hard now. Mark, do you want to start with that?
Sure. And, Irwin really highlighted this. Other than a short-term slowdown, there's been an insatiable appetite for healthcare assets nationally, and I don't think that's going to slow down anytime soon. You know, we've had billions and billions of healthcare assets transact in each of the last 3-4 years, and all the big REITs, private equity funds, and individual investors like ourselves, you know, want to buy what is viewed as a long-term stable asset, and it really differentiates itself from other asset classes and asset types. So, you know, I don't think that's going to slow down. I think there's all the capital that's needed to acquire. The issue really is, you know, with the stock market going down dramatically, the big REITs really sat on the market. Others stepped in to take up some of that slack. But I think once our pause is over and we're back on flying to evaluate acquisition possibilities, it'll come back robustly. And by the end of the year, cap rates will come back down to where they were pre-COVID, and we'll be back into the same cycle. The issue on valuations, you know, it's really a trailing issue in terms of taking sold properties for your current valuations. I'm not seeing any great impact of that. You know, the issue has been good healthcare assets have been trading in the 5.5 cap plus minus range up to 6. That's moved a little now just because of the risk in the market currently, but I think it'll get back down, at least for well-positioned assets, back into the 5s strongly. And there are even we have one of our 3 buildings that we're buying in Tennessee that's under a 6 cap that we agreed to. And so interest rates are still low. You know, you're down into the mid 3s in terms of financing rates today for long-term rates. And so I don't think we've in any way changed the economics of acquisition today. And so I think that'll stay strong. And valuations, I'm not sure there'll be enough closings to impact, you know, how people are looking at the assets that have closed on a sale basis going forward.
I think too, what I would add, if it comes down to that's true of acquisitions and 100% leased buildings or stabilized buildings, but from a development perspective, it's a matter of you know, how much speculation is in the building. If you have something that's only 70% pre-leased, that's going to get a lot more. The underwriting is going to be a lot tougher on that. Lenders are taking a harder look at it. Investors are taking a harder look at it, and so that's where you see some of the price softening in that area. But good quality credit, good quality buildings with that are stabilized are still commanding a premium, I'd say.
Mark, not to put you on the spot, but with some of the other sectors such as retail or maybe generic office being negatively affected by COVID, do you see any of those buyers or owners maybe looking to transition to medical?
As I think all of us know, it seems like when everything else is having difficulty, everybody wants to get in medical, and then when the economy improves, then they're back out looking at their other functional areas. On a development side, I think it comes down to, you know, people in times of difficulty rely on those that have lots of experience in the marketplace, and so it's really tough to break in a difficult market. And there's always those one-off relationships where people develop a medical building rather than, you know, people that have been and do that all day in and day out. But I don't think we're going to see a lot of people that move in that direction. I think on the acquisition side, there's a really healthy appetite of groups, even the large funds in the country that are looking to have major acquisitions of medical product. And there's not enough large acquisition appetite to product to go around in terms of the demand that's there.
I hate to jump in, but I have to. I got to get another CE question in. And I noticed, I think somebody just answered the first CE question. I'm not sure answering the question 40 minutes later is going to cut mustard on the Department of Commerce, but I'm no expert. So anyway, last question. And this is a personal one. I've been tracking COVID closely because we want to get back to live events and we want people to be comfortable to get back to live events. So I'd like to know where people's heads are, where they think it's going. Our governor in Minnesota was adamant that we would have a spike this summer. But the evidence over the last 2 or 3 weeks is that it's continuing to go way down as a whole and as a percentage of the tests being taken. So what are people's thoughts in the audience now? So this is just a yes or a two-part question. One or the answer. Either you think yes, we're going to have a spike this summer, or no, it's just going to fizzle out. The COVID's going to fizzle out as the hot summer goes on. So thank you for answering that. And you all have 10 minutes, and I'll come back when we're.
Do we want to stick with capital evaluations, or do we feel comfortable with that, or do we want to move on? Anybody else?
I had a thought, but I was distracted by the question. I think the onset of school, and as we head into the fall, where typically viruses come in, that's where I think we'll see the surge.
Yeah, having read it, like Harvard's done an awful lot of reports on this lately, and if you read what they say, who knows for sure, but it certainly has the ability to come back again. But I think it's going to be later than some people thought. All right, well, let's move on then. Let's so since we only have 10 minutes left, let's take a broader question. What is the outlook for healthcare investment given COVID-19? And let's make it really broad. Instead of it just being that, cap rates come back and people still want to do healthcare, for sure, obviously, Mike Fleeta once told me that when healthcare is a slow train, it's nice and flat and it just grows at a real low percentage over a long period of time. And when everything else is in the, down in the tank and healthcare looks great, when everything else looks really good, people stop looking at healthcare. And I think that's been a norm for a long time. But I think this drop in the whole market, for that matter, has been very short-lived, and it's very force majeure driven. It's been, from a single event that should be recoverable, somewhat more differently than a major market collapse, for example. So looking at this as broadly as possible, just from not only from the standpoint of healthcare being a preferred investment type typically anyway, but also for how does investment change into it, and what kinds of facilities adjustments are necessary in order to make the product going forward interesting, given the output of COVID-19. And I will just throw one more caveat on that. I think if you look at South Korea, who got hit by both MERS and SARS, they responded very differently to this COVID outbreak than most other places, and they were also out of it a lot faster. They've had experience with it before, and they reacted quicker, both with their facilities and their approach. And I wonder now, too, that we've gone through it once, if our next time around, when it does come back again, which something will, do we have a different response, facilities-wise?
I think that because of the demand and our baby boomers and low interest rates and so many other things going on, including COVID, and the surveys of national developers and investors and health systems out there would tell you that we're going to see, and the continued trend to outpatient, we're going to see more medical office buildings, more outpatient development, more equal or more opportunities in those areas. There's no doubt about it. And in the COVID, people are saying, it would have been nice if we would have had more outpatient facilities, and maybe we could have kept aspects of our business going instead of having so much on campus. And I think that's true of ambulatory surgery centers in particular. So you did have the PPE concern, but I think you'll see a lot more acceleration of outpatient facilities. And medical office buildings are arguably the most flexible form of facility you can have for healthcare. So you're going to see more of that rather than the inpatient. And I caution everybody too, early on people were saying, this is my personal opinion, so take it for what it's worth, but speaking to a lot of designers and everybody, oh, we're going to redesign the world. We're going to redesign every facility. We got to figure this out. This is the future. I think we're going to get through this. It will pass. We will live with it forever in some respects, but people are people, and they're going to get back to being close to one another, shaking hands, getting on a patio, drinking beers, going to concerts, having a good time. You know, and then from a facility development and investment standpoint, you know, our healthcare system is still struggling and still needs the cash. It's got a lot of constraints out there. So we can't, when you get back to the table and you're planning out that new facility, the first costs will come up. You can't get gas to every single inpatient room and head wall in the facility for that total flexibility. There's going to be tough choices still, and so I'd caution everybody that we will not spend wildly on redesigning the world and rebuilding everything.
You know, I would agree with Erwin that there is going to be an acceleration of care moving out into the ambulatory setting. It's being facilitated by the expansion of reimbursements through CMS. We'll see it in the commercial sector as well. But, you know, at the end of the day, the financial impact that COVID has had on healthcare organizations is really going to prompt the healthcare organization to rethink how is it using its real estate and facility strategy to recapture lost revenue, number two, to reduce cost. And part of that strategy will be around how do we use our existing infrastructure? How can we create, particularly for any own assets, how can we create and lean out our existing infrastructure so that it is a flexible environment to be able to deliver care? This coupled, you know, with operational strategies around optimizing some of the higher margin service lines, again, leaning out the system. I think these are going to be important factors to take into consideration as we're moving out of COVID.
Mark, Brian, you guys want to throw in on that at all?
No, both Chantilly and Erwin said it well, so I'm good.
Well, I'll Brian, anything? Okay, so here's a thought just to pony in on that too. So ambulatory is more profitable than inpatient, and I think there's been a drive for quite some time because of the systems realize that. I think if I remember hearing this last winter, I think ambulatories are about 5% profitability, whereas inpatients only like 1.5% profitability. So there's been a lot of financial reason to try and push to the outpatient as opposed to the inpatient. Do you think that this gives an easier reason or easier method to try and push towards more outpatient facilities, or conversion, as Chantilly points out, of inpatient facilities to outpatient facilities?
Hey, Chris, I think we've seen long ago that healthcare was pushing out into the community, wanted to be closer to the community because of the cost issues that you just spoke about. And so I don't think that will change. I think we've also seen one of our good partners is Physician Realty Trust out of Milwaukee, and they really are focused on outpatient medical assets off hospital campuses today in their acquisition strategy. So they've really gone away. You know, it wasn't too many years ago, and Erwin and Chantilly and Brian can talk to this, but you know, people put a pretty significant premium on on-campus assets, healthcare assets, in terms of their acquisition pricing. Today, it's really a very small margin, and if you have a health system or credit tenant related tenancy base in your suburban medical office building, there's virtually no difference in pricing from on-campus, or at least it's a very small margin. So things have really changed over the last 5 to 10 years, and I think there will continue to be suburban, closer to home type strategies for most health players. I think the interesting thing as we come out of COVID and the financial pressures that Chantilly talked about, will groups start to think about consolidation? Do you need 3 in the marketplace, in the suburban marketplace? Can you get by with 2? Can you expand one that's already existing and close down one? In terms of helping your overhead and your employee counts. And so it'll be interesting to see how that plays out as we go through the next year.
Todd, how are we doing on time?
You all are welcome to go over as long as you want because we record it. I see we're still at, we've had a lot of people are still here watching right now. But I'm going to start putting up the slides to sort of wrap this up, and I'll let you keep talking if you want to keep going. I don't see any new questions unless you do, Chris.
No,
okay. So maybe just go around and wrap it up, and I'll pop through these ending slides. Is that okay?
Sure. Mark, you just brought up a good point. There's a physician group here in town that has 16 locations under 4 different practice names. A couple of those locations are literally across the street from each other, and they don't rebrand them. They keep them independent so that they draw a different patient load. Do you think those kinds of groups will look at consolidation just from a staffing standpoint or from an efficiency standpoint, or do you think they'll continue to try and deliver care from a more of a choice perspective?
Personally, I think they're going to look at consolidation strategies to save money. I think across the board, every group has experienced a downturn in their business and some pain through this COVID process. And I think, we have a fairly large group that we're working with that specifically is focused on consolidation. And I think we're going to see more of that. And I think that'll make the market healthier as we go forward. And so I think that will happen.
Erwin, Chantilly, Brian, any other thoughts you guys might have to throw in at the end here?
No, thank you.
Agree. Thank you.
Thanks, Chris, for putting this on. And
it was fun. Well, we all work together on it, so it's always enjoyable to work with you guys.
I'm going to flip through contact info. If y'all want to log off, go ahead. I see people are logging off in the chat room. If you're here for CE, doesn't hurt to put your name down one more time. I see people are putting their license number down. Doesn't hurt at all. Belt and suspenders approach. Make sure you get that credit because we're nearing the deadline. What a great panel. Thanks, everybody. Look forward to working together and doing more soon.
Thanks, guys.
Thank you, everybody.
Anytime. Absolutely.